As with most of our oral agents, they don't work forever for most people, and we do still develop resistance. Resistance can be in multiple forms. It can be on-target resistance, which would be in the form of new RET mutations. The cancer alters the target so that the medicine no longer binds as tightly. The medicine is no longer effective. Those are on-target resistance mechanisms. Or there can be off-target resistance mechanisms where the RET is still being blocked, but it's now using a different pathway to survive, such as MET or KRAS. In those settings, possibly combinations or switching to a different strategy might work. If it's on target, perhaps a new generation RET inhibitor. And we do have new generation RET inhibitors. I think it's a little too early to go into most of these. They're all still license plate names with letters and numbers, but we do see some promising activity after prior drugs. We're working on these now. These are open at various centers, including Dr. Nagasaka's and mine, and we'll work on developing the next generation of drugs for those who need it. But importantly, immunotherapy is really not so effective for RET fusion lung cancers. The Immunotarget Registry, which was led by Dr. Julien Mazieres in France in Toulouse, looked at PD-1 and PD-L1 monotherapy. And what they saw was that for RET fusion positive lung cancer, the chance of response was only 6%, and 75% of patients had an immediate progression with no periods of stability. And so if targeted therapy is no longer the option and the trials aren't available, chemotherapy is much strongly preferred over immunotherapy. RET can also be responsible for resistance. And we can see, for example, in an EGFR lung cancer that's being treated with osimertinib, a new RET fusion can emerge, which allows that tumor to survive. And so off target for others, such as EGFR, and you can see pralsetinib being used, or selpercatinib being used. On the left, a case from Dr. Zosia Piotrowska. On the right was one of our patients at Georgetown. We're also trying to use these drugs in the early stage setting because they're well tolerated, because they work well in the brain. We think maybe they'll work as osimertinib works in the early stage setting. And so they are looking at adjuvant RET inhibitors after surgery. That's the Libretto trial. And this is ongoing now. It'll be a while before we get results. But RET fusions, rare but important events to identify. Selective RET inhibitors, very effective.